As any invasive heart procedures, there are risks with it. So for example, for a simple angiogram, we give them around 1 in 1,000 chance of things going wrong during the procedure, which includes stroke, heart attack, emergency operation if things go wrong, or even dying on the table. A simple angiogram. This is called PCSK9 inhibitor. So these are injectable drugs which aggressively controls your cholesterol. Hot topic in intervention cardiology, other than stents, has always been something called a shockwave balloon. So bioabsorbable scaffolds will come back. This is my personal opinion. 2 years ago, where they compared stents versus balloons in small vessels. And I think that's where the future technology should focus on, these drug-coated balloons and scaffolds. Patients with established heart disease, especially if they have a left ventricular dysfunction, they do very badly once they get COVID-19 earlier. So once they develop inflammation, there'll be a damage of heart muscle, there'll be a death of certain heart muscles. So essentially, if you already have, let's say, ejection fraction of 35%, and you develop COVID-related myocarditis and you drop your ejection fraction to 25%, then you do very badly because you've taken more hit on your heart muscle. There are concerns about use of ACE inhibitor and angiotensin receptor blockade in patients, making them vulnerable for COVID-19. I think these should all be evidence-based. I mean, the evidence is weak, so it's not proven to work. A marathon, your cardiology career or your any career, as a matter of fact, is a marathon, not a sprint.
We need more doctors in the world?
I think that certainly we need more doctors in the world.
Welcome to Docsvalley's Reflections, a platform where we have very exciting and insightful conversations with healthcare professionals in their field of expertise. Today, we have a very special guest, Dr. Sandeep Basavarajaiah, who is a consultant cardiologist at the National Health Services, UK. He's a consultant cardiologist at the Good Hope Hospital or Heartland Hospital, University of Birmingham, UK. Dr. Sandeep's interests are all aspects of general cardiology, including coronary intervention. His main job is to undertake angioplasty, that's including stent procedures in patients with angina and heart attacks. He's also a specialist in opening long-standing blocked arteries of the heart and undertake complex procedures, which require a very specialist skill set. He regularly visits other countries to train cardiologists in the field of expertise. Dr. Sandeep has an extensive interest in academic activities, including teaching, and also doing research. He has published many papers, research articles in high-impact journals, and he's also presented at various national and international leading conferences. Dr. Sandeep, welcome to Docsvalley's Reflections. We are very pleased to have you with us today, and thank you for giving us the time despite you being very busy in this kind of a pandemic situation, which requires doctors to be available all the time. To start with, NHS is, as we all know, is one of the oldest, one of the largest, and one of the finest healthcare systems in the world. The current coronavirus situation has put almost all healthcare systems across the world into a real test, to its maximum test. You as a doctor, you still have to get up and go to the hospital and save lives every day. How you as a cardiologist coping up with this kind of unprecedented situation?
Thank you, Yashwant. First of all, thank you for giving me this opportunity to interact with you all. It's a great pleasure. As you have rightly said, this coronavirus or a COVID-19 pandemic has shaken a lot of countries, and they put their health system at a maximum challenge. And we are going through the same in the UK. So we are dealing with the pressure because Birmingham, where I work, is one of the second largest city in the UK, and it's been affected the most after London. So we are facing a lot of challenges in the hospital. So as a cardiologist, I have to deal with this COVID-19 patients, along with patients who have heart attacks and angina. So we are now working in a shift system where we work 4 days, 12-hour shifts, and then we take 4 days off. This is to kind of ease the pressure on the healthcare professionals as well, so that we are not overworked. But it is a challenge, but we are getting through. And obviously, we've got expect worse to come through in the next 2 to 3 weeks, and we are ready. We are getting ready for that.
As they say, prevention is better than cure. Could you tell us, as far as cardiac health is concerned, in the primary and secondary prevention stage, what steps do you take to educate patients?
As you rightly said, in the Western world, especially in the last 1 to 2 decades, we are focusing more on primary prevention. So, identifying patients who are at risk of having heart disease, like, identifying diabetes, treating it accordingly, so as cholesterol levels, focusing on giving them advice about exercise, smoking, leading a healthy lifestyle. So we in the UK are very privileged to have a British Heart Foundation, which is a very big organization which provides a lot of information to patients in the form of leaflets, billboards, TV ads, and lots of educational program where we focus patients on providing primary prevention so that they don't develop cardiac disease. And this is what we've been doing in the last 20 years, and it has worked. So as I said, more focus is on primary prevention than going for a secondary prevention.
Once you identify a patient is in a high-risk category, could you tell us what tools do you use for cardiac risk assessment checks?
So we use something called a Q score, which is quite extensive scoring system, which incorporates a lot of things like their family history, cholesterol levels, diabetes, all the risk factors, and gives us a scoring. So, for example, if you have a Q risk of something like a 30, 35%, which essentially means that in the next 10 years, the person is at a risk of having a cardiac event or a stroke is around 35%. So the scoring system is quite good because you can then categorize patients to sort of high risk or a low risk category and then treat accordingly. So if we do identify patients who are high risk, so we focus quite aggressively on controlling their risk factors. Like, for example, smoking, giving them aggressive, treating their blood pressure, and giving them a lot of advice on how to lead a healthy lifestyle. So that's how we deal with the patients who are high risk.
This Q risk scale is only specific to UK, or many other countries around the world are implementing the similar scale that you just mentioned?
Yeah, I mean, look, Q risk is an online scoring system. You can access anywhere you want, and it's validated nicely. So it's not just subjected or validated to just a UK population. It can be used globally. It's a good scoring system, which we use, mainly used by general practitioners in the UK, although we too use them because by the time we see patients, they already have established heart disease or a suspected heart disease. So mainly the general practitioners see these kind of patients and they use a Q-risk scoring system.
Thank you. Could you please elaborate on the importance of preventive medicines in both primary and secondary prevention stage? I'm more specifically interested in preventive medicines like statins, for example, the use of statins to minimize cardiovascular risk. Please, can you elaborate the risks and benefits of using statins in treating cardiac ailments?
Look, primary prevention itself is very effective, irrespective of statins. So if you just take blood pressure, or smoking, for example, if you tell the patients to stop smoking or quit smoking and give them support, that itself is the biggest reduction of incidence of cardiac disease. So primary prevention, no doubt, carries a very, very important weightage in preventing heart disease. Statins, if you want to go in detail, now look, statins can be overprescribed, and of course we are blamed from the general public saying, look, maybe it's a pharmacy or a industry driven. But at the same time, there is a lot of evidence that the statins work, especially in patients with established heart disease. Now, for primary prevention, statins shouldn't be overused. So, for example, if I identify someone with a high cholesterol, we just don't take just the cholesterol. We take other parameters like a good cholesterol, like HDL, LDL, the ratio. And of course, if the ratio is higher, if they have a high cholesterol, then we first go for a lifestyle management, because a lot of the time that works. So, giving them advice about lifestyle, eating healthy, eating more vegetables, avoiding, like a red meat and, increased carbohydrates, etc. So if you do that and then recheck their cholesterol, and if it's all back to normal in the normal range, then they don't need statins. But if the cholesterol is still very high, and if this person is in a Q risk of more than 10%, as I mentioned earlier, then certainly statins will help with these patients. And I would certainly recommend statins in these patients. So that's how we practice in the UK.
I guess once the primary prevention and secondary prevention doesn't work, obviously then the intervention comes in. Could you please tell us what are the invasive treatments available for patients with coronary artery disease?
Sure. So look, after primary prevention, we only investigate patients with coronary angiography is if they have symptoms. If patients don't have symptoms, we shouldn't subject them for just an angiogram just to see what their arteries look like, even if they have a high risk factors like family members with coronary disease. Because if you identify a coronary disease in someone who's totally asymptomatic, we shouldn't be giving any invasive treatment at all. The indication for invasive treatment is either if patients have angina, which is not responding to medical therapy, or if they have an important coronary disease, which will affect the prognosis of patients, or if they have a heart attack. So we do angiogram to understand the coronary anatomy, see where is the blockage and where is the disease. And if the disease is in a small artery or in a non-prognostically important arteries, we still recommend medical treatment. Because if the medical treatment works, they don't need stent treatment. However, if the medical treatment fails, i.e., if they are symptomatic despite 2 anti-anginal therapy, then we offer them angioplasty with stents. So essentially, it's a procedure where we, put catheters in the arteries, dilate the narrowing with a balloon, and then implant a stent, which is like a metal scaffolding, so that it doesn't collapse again. Although we are using other technology, which I'll come to that later.
Are there any specific risks associated with these invasive treatments?
Certainly, look, as any invasive heart procedures, there are risks with it. So, for example, for a simple angiogram, we give them around 1 in 1,000 chance of things going wrong during the procedure, which includes stroke, heart attack, emergency operation if things go wrong, or even dying on the table with a simple angiogram. Whereas if you're doing stent procedure, the risk goes up to sort of 1 in 100. And again, these are all simple stent procedure. Again, if you are undertaking more complex procedure, the risk goes up. So in some cases, we even say 5 to 10% risk of having major complications. So any invasive procedure with the heart carries risks. And this has to be kept in mind before offering any stent treatment to patients.
Obviously, your expertise is stent treatments and bypass surgeries. And that's where you spend a lot of time. Can you please tell us what are the pros and cons associated with bypass surgery and stent treatments in specific?
Sure. Look, once you have a narrowing in the arteries of the heart, then there are 3 options, as I said: medical treatment, then you have a stent, then you have a bypass surgery. So what qualifies patients for bypass surgery are, for example, imagine just like any road. If there are 1 or 2 places which is damaged, you just do a patchwork. Whereas if the road is quite extensively damaged, then we use something called like building a new road, which is what a bypass surgery is. And there are certain parameters we consider. So for example, if patients are diabetic, if they have triple vessel disease, then they do better with a bypass surgery, especially in the long term. Whereas if they have 1 or 2 areas where you can put stents in, we go for stents. The pros and cons are obviously the advantages of having a stents are it's a very minimally invasive procedure. Patients are completely awake during the procedure. They pretty much go home the same day. The recovery is usually within 2-3 days. They're back to normal. In fact, a lot of my patients get back to work within a week after the procedure. Whereas bypass surgery is a more invasive procedure. Patients have to be in the hospital for a minimum at least a week, 10 days, maybe longer. And there are risks with the bypass surgery. The healing of the wound can take time, especially if they're diabetic. The wound healing may take time. Patients' recovery is relatively longer. Whereas, as I said, there are certain lesions and there are certain patients who benefit from bypass surgery because it gives a better long-term results, because stents, although it looks great, stents can narrow. And once the stents narrow, it's very difficult to treat. So we do have something called a multidisciplinary team meeting or a heart team meeting in our center. I mean, most centers in the UK have it. So we do discuss cases, and we take a consensus opinion from other cardiologists and surgeons, and then we decide. Of course, it also consider patient choice. So some patients may say, look, I don't want an operation at all. I want stents. And there are some patients who have had a bad experience with stent, either by themselves or some of their relatives, and they won't have surgery. So we do take patients' opinion as well.
Just for the convenience of our diverse audience, could you tell a little bit more detail about what are these stents made of and how does it work actually?
Sure. So stents are basically a metal scaffolding, and the current generation stents are made of special alloys. So one group we have a platinum chromium, the other group we have a cobalt chromium. So these are the metal platforms, and on which there is special drugs which are coated, either everolimus or a zotolimus or a biolimus drugs. These are the drugs coated on the stents. So basically, these drugs prevent excessive growth of tissues within the stent. Now, how the stent work is essentially when you have a narrowing in an artery, so you stretch the narrowing with the balloon, and there's always a chance it will collapse again. And to prevent that, we provide a scaffold. Like when you're building a house, you have the scaffold. And essentially what it does is it stops the artery going back to its original or narrowed state. That's how the stent works. And after a while, what will happen is your own tissue grows inside the stent, and then the stent will become part of your body. So it's mainly a scaffold which it provides. And the drug on the stent will stop excessive growth of tissue within the stent.
I'm curious to know what happens to stents after the treatment actually?
So what will happen is once you deploy the stent, over the next few days, your body will start coating the stents with its own cell called endothelium. So once it covers, then your stent will become part of your body. So once stent goes in, you cannot take it out. It becomes part of your body, and your body won't react to that stent anymore, especially when it's covered with a coating.
And are there any proven alternatives available for stents at the moment, or is that the only option available?
No, it's a good point you asked me, because we are increasingly using what we call a drug-coated balloon, which are essentially a balloon which have been coated with the similar drugs that goes on stents. The idea behind it is, for example, stents are great, but as you put long layer of stent, like in terms of length, or if you're putting stents in a small arteries, it increases the risk of what we call restenosis, or the stents which narrow within the stent, narrowing can develop. Once it develops, it's very difficult to treat, because once the stent starts narrowing, no matter what you do, the recurrence rate of restenosis is high. It's over 15%. So we want to avoid stents in certain lesion. As I said, it's a long lesion, small vessel, or if you want to treat patients who can't take blood thinners. So for example, once you have a stent treatment, you have to be on a blood thinners, aspirin and clopidogrel, for at least 6 months or maybe even a year. Whereas with these drug-coated balloons, because there is no metal, there is no polymer, all we have a drug which goes away within a month in the body. The patients can only take aspirin and clopidogrel for a month, after which you can stop one of the antiplatelet therapy. So patients who can't take antiplatelet therapy, for example, if they have any bleeding problems, or if they're waiting for an urgent surgery like cancer surgery, we are using drug-coated balloon. Now, drug-coated balloons have been around for almost more than 10 years now, but they've been increasingly used now. And we are one of the leading centers in the UK to adopt this technology. So in my practice, I use probably around 25 to 30% of the cases with, or treat the patients with drug-coated balloon, because I do feel that they have an excellent role in places where you want to avoid using stents.
That's great to hear that at your center you use an alternative like drug-coated balloons quite extensively. But I guess it's not for everyone, isn't it? It's very subjective, and not everyone qualifies for it.
Yeah, I mean, as I said, not everyone qualifies for a drug-coated balloon, and I don't think so drug-coated balloon will ever replace stents completely. But I'm sure from my experience so far, it does carry some indications. I would say 25 to 30% of cases can be treated with drug-coated balloon. And in fact, it avoids long-term complications like stent thrombosis or restenosis with a drug-coated balloon. And in fact, a point to make that one of the drug-coated balloons in the market is from India. It's produced in Surat, and it's one of the biggest companies now producing a special balloon called sirolimus-coated balloon.
Obviously, after the invasive procedure comes the post-operative care, and especially the role of medicines in blood, like blood thinners, and how do you mitigate the complications that may occur due to blood thinners? I'm referring to their association with like preventing strokes or internal bleeding complications associated with them. Could you tell us a bit more about that?
That's a very good point. See, as I said, once you use a stent and it is a foreign material, and your body will react to it, and it can form a clot within the stent. So, which is why we use blood thinners, so aspirin, clopidogrel, or ticagrelor, or prasugrel. These are some of the antiplatelet therapy. What it does is it blinds the platelets to the stent, so that the platelets will not see the stent, and then hence don't form the clot. Now, these medications are given for a minimum of 6 months or even up to a year, sometimes even beyond a year, especially if you've undertaken a very complex angioplasty. So certainly once you go on these medications, it increases the risk of bleeding, especially elderly patients or if they have pre-existing bleeding conditions. So it's very important how do you select these patients, which is why I was saying medical therapy still has a role. So a lot of patients, you can just manage medically. Patient compliance is very important. There's no point you doing a great job and patients don't take the tablets and then, stents will block. Or if they develop any bleeding problems. So these are the precautions we tell patients about. Once you have a stent, you have to be on blood thinner so they understand it. And it's a balance. In some patients, we stop at 6 months because they are at a high risk of bleeding. In some patients, we go beyond a year. If they're young patients, if they have had a complex procedure, in fact, I've given it more than a year. Yes, there are risks with the bleeding. But at the same time, if you don't take it, then you risk stent thrombosis, which is very fatal. 30% of patients with stent thrombosis die.
You obviously travel across the world and you meet a lot of cardiologists from different countries, and you must have seen the data. What difference do you see in prevention, treatment, and post-operative care of cardiac patients when you compare the approach taken in UK or Europe versus, let's say, Asia or other countries? My question is, this is from both patient and medic's point of view as well. My question is related to early detection issues. Some countries, the patients may not be aware of the symptoms, and by the time they come to the hospital, the issue would have deteriorated, and the complications may already set in before they come and see the doctor. Could you tell what is the difference do you see between the countries?
Well, I mean, the healthcare system changes, from country to country. So I've been fortunate to work in the NHS, which is mainly driven by the government. A lot of the countries in the world rely more on private healthcare. So in terms of, the way things are dealt in UK, one of the good things about post-operative, as you said, we have something called a cardiac rehab, which is quite extensively set up in the UK. So after having stents, either in the form of following angina or a heart attack, they undergo through undergo a 6 weeks of cardiac rehab where the patients are taught how to build their exercise tolerance, gradually get back to their normal lifestyle, their advice on lifestyle, smoking, etc. And it's done in a group, so they all be part of an exercise group. So it's an amazing a program which has been set up in the UK by British Heart Foundation. That I see lacking in certain countries because it's very easy to put stents and give some advice to patients, but after that, whether the patients are taking medications, whether they're getting support is what has to be established. So I think I would like to see more of cardiac rehab established in other parts of the world, especially in India. India it's a great country. It's doing extremely well in terms of a healthcare system. We've seen a lot of technologies which are used in India, not available in the UK. So they're doing extremely well. But there are certain aspects. So for example, primary prevention, we can still do better in India, because it's very easy to put stents and things, but we should avoid patients coming to that stage. So more focus has to be put on primary prevention in India, like educating patients, even the cardiologists, general practitioners, giving more information. I think these kind of programs you're doing are excellent because it is approached by, it is heard by lots of non-healthcare professionals or even patients, so it helps them. I think for me, that's where the cardiac rehab, primary prevention is where we should be focusing more. And obviously involving patients is very important. Patient education is extremely important, so they should understand their role in their own heart condition.
I'm just diving a bit more technical again. Could you tell us more about a role of injectable cholesterol-lowering drugs and who qualifies for it?
Sure. This is called PCSK9 inhibitor. So these are injectable drugs which aggressively controls your cholesterol. Now, in the UK, the current situation is such that I myself, as a cardiologist, can't prescribe these drugs. We have a specialist for this called lipidologist, and they do run a specific or a special clinic, and we do refer these patients to them. So saying, look, can this patient be considered for injectable cholesterol-lowering drugs, PCSK inhibitor? The indications are, so for example, if you have a younger patient with extensive heart disease and cholesterol not getting controlled with usual statins, there are younger patients who have a very aggressive coronary disease and the cholesterol level is borderline, are also qualifiable. So we leave it to the discretion of the prescribing specialist, so that's the lipidologist and the patient. But it does carry a huge role in reducing the cholesterol levels and hence preventing further progression of heart disease.
One of the most widely discussed and researched topics is certain populations are more susceptible to cardiac complications than other populations. For example, if you take Asians, particularly Southeast Asians, when you compare their risk of cardiac complication, which is much higher than, for example, European population. I just want to understand, why is that? Is it because of our genetic makeup in Southeast Asians? Or is it due to the lifestyle changes or the food habits? What exactly is the reason for this susceptibility between different populations?
I think that's a very good question. It is proven well beyond doubt that Southeast Asians, so Indians and Sri Lankans and Pakistanis and Bangladesh, they're at a high risk of developing heart disease. And because their genetic makeup itself, they are vulnerable for developing heart disease. And secondly, incidence of diabetes is very high in this part of the world. That itself will contribute. Then generally Asians have a smaller arteries as compared to Caucasians, so they're vulnerable for more stenosis much quickly than the Caucasians. And obviously, in along with this, the lifestyle itself, smoking and things are, sedentary habits have also played a role, but which can be modifiable. But what you can't modify is your genetic makeup. So certainly we are at a high risk, Southeast Asians. And as I said, it also makes them vulnerable for diabetes. So this to itself is sufficient them to be at a higher risk than Caucasians.
Could you tell us about any specific new technology that or medicines that you're working on, which may benefit cardiologists and the patients in the future? I'm more curious to know a bit more about technology like drug-eluting stent technology. There was a lot of hype many years back about bioresorbable stent technologies as the way for the future, but that hasn't happened. Absorbed stents, as you know, was not able to match the performance or outcomes of the current standard care metallic drug-eluting stents, according to many doctors. I think it was in 2017, if I correct me if I'm wrong, in 2017, the absorb stents was pulled off the market, and the innovators or researchers are now focusing more on refining the metallic drug-eluting stents. You as a expert in this area, where do you want the researchers or vendors to focus on in stent technologies to offer better outcomes in invasive procedures?
Thank you. Look, the current hot topic in intervention cardiology, other than stents, has always been something called a shockwave balloon. I don't know whether you've heard of it. It's a special balloon which delivers shock. So if you have an artery filled with calcium, conventionally we used to crack the artery with the balloons or a rotational atherectomy. But sometimes when the calcium is deep-seated, you can't reach the calcium because you don't have any tools to reach that depth of calcium. So we are now using a shockwave balloon, which essentially delivers pulse of shockwave to crack these calcium, so you can deliver the stents properly or expand the stents adequately. That is current hot topic in interventional cardiology, and it has changed the practice a lot across the world. In fact, I came to a meeting in India only a couple of months ago, India Live, and it was the hot topic even in India now. That is to do with the balloon. Now, coming to the stents, look, we have done extremely well with the drug-eluting stents. Now, they were kind of introduced in 2001, were the first generation stents made of stainless steel. And we used to use some different drugs, but now we have alloy, and more importantly, we have stents which doesn't have polymer in it. No polymer or bioabsorbable polymer. Coating of the drug itself is more on the outside of the stent rather than inside, so that it doesn't affect the stent healing. So drug-eluting stents have done extremely well. I would probably say there's very little improvement you could do in drug-eluting stents, because the current stents we have, they're doing extremely well in a very low rates of stent thrombosis and restenosis. Bioabsorbable stents, or the scaffolds, they were initially, everyone thought it's going to, do very well. I had some reservation about it. I'll tell you why. Because these were not like your stents; they're like a plastic. The other thing about this was they were reserved for certain patient lesions and subsets, not for everyone. Once they were released into the market, it was used in most patients, and it's not like your stents where you have a metal where you can really push hard and to expand the lesion. If you don't prepare the lesion very well, the bioabsorbable scaffolds won't be delivered or won't be deployed very well in the lesion, which means it can collapse, it can break, and it can form stent thrombosis, which is what happened. So the most important thing bioabsorbable scaffold was to lesion preparation and patient selection. You shouldn't be putting bioabsorbable scaffold in all patients, which is what kind of happened in a way. So everyone thought it should be treated or tested in all lesions. I personally feel we have used bioabsorbable scaffold in certain lesions, especially long LAD lesions, and we have had some excellent results, and patients have done really well. So bioabsorbable scaffolds will come back. This is my personal opinion. It'll come back, but we don't know when. Currently research is going on. It's not used in clinical practice, but something, we should focus on this to improve the technology, making the scaffolds a bit more thinner, a bit more durable. And if that happens, it will come back. And again, it won't replace the metallic stents altogether, because these are reserved only in certain patient population and lesion subset. So I think these are the advances. And as I said to you, drug-coated balloon is something which we are increasingly using. And that is somewhere the research is currently going on to test more and more lesions and comparing with stents. We already have a major trial, had a major trial 2 years ago where they compared stents versus balloons in small vessels. And I think that's where the future technology should focus on, these drug-coated balloons and scaffolds. And in fact, as I said to you, there is a special drug-coated balloons from India called sirolimus-coated balloon, which is also being currently tested on trials. So these are the areas where we can focus on, and it's exciting times for us.
I know we just touched base at the start. Given your research interest and the articles that you have published, could you talk about your research areas of interest and any specific technologies that you are working on which could become available in the near future, which you think other cardiologists or doctors should know?
Look, my interest is interventional cardiology, but again, interventional cardiology has got a lot of subspecialties. So my main interest is opening this chronically occluded arteries, or arteries which have been blocked for a long time, and it needs a special skill set and training which have been received from one of my mentors from Japan. So we are now researching on a blocked artery within a previously placed stent called intra-stent occlusion. So we have a biggest database of it, and we are currently in the process of writing a paper on it to see what are the long-term outcomes of these blocked stents, and also what are the best treatment strategies, whether to go for another stent or just a balloon or a special drug-coated balloons. And my other areas of interest is drug-coated balloon technology, which have been extensively involved since 2012. So we are using these drug-coated balloons in small vessels and patients who can't take blood thinners for an extended period of time. And we are researching on a special balloon which has sirolimus. Most of the drug-coated balloons available in the market have paclitaxel drug on it, which is a special kind of drug. The only problem with the paclitaxel is it's a toxic drug, and it's a very narrow therapeutic window. And there are some reports in the peripheral intervention that there may be an increased risk of mortality in patients who have received these special balloons. So the new technology is on sirolimus-coated, which is a drug which is less toxic and in fact more used on stents. So we are working on this technology. We have a lot of patients treated with this. We have got ongoing follow-up. We are in the process of publishing a paper which is almost accepted in a journal. That's my second interest. And my last interest is a Shockwave, which is currently one of the, we could call a big leap in coronary intervention of treating intracoronary calcium in a safe way as compared to what we were doing in the past. And there are several studies which has come out, and we have now a sort of registry data from our center with lots of other centers in the UK and Europe. So that's where my interests are.
These technologies that you just mentioned, what kind of timelines are we looking at? I think some of them are already in use, or some of them would become available. Can you tell a little bit more about that?
No, look, Shockwave is already available clinically. So it's used in a lot of centers in the UK. In fact, in our hospital, we have used in almost 80, 90 patients. In other parts of the world, it is coming. So, for example, in India, they only recently used in the live conference which I went in Delhi. So it's already available. The Shockwave is already available. But what we don't know is what is the long-term data, how does it behave, how efficient it is. So, which is what all the papers will come out. So, our data, for example, is a real-world data on patients we have treated. And we have excellent data or outcome of it, so that we have a very good safety margin and very good outcome so far. But we need more papers and more results, like the bioabsorbable scaffolds. They came out very nicely. On a few years later, we realized that it's not as good as stents. So only the long-term data will say. It's been around for so many years now. The paclitaxel balloons are always used in every centers. But the sirolimus-coated balloon is a relatively novel technology, which some centers have embarked. A few centers in the UK, we are one of the biggest centers. which we are doing some research on it, comparing with the paclitaxel's balloons. That is also available. They're CE marked. And so once you get CE marked, you can use in Europe. And that's what we have been using. So yes, that's probably, and the CTOs, as I said, it's escalating globally. So all these are available for clinical use.
That's a great insight. Just sort of going back into the current COVID-19 situation, could you tell us about what do cardiologists need to know about COVID-19, mainly regarding cardiac-specific preparedness for COVID-19, and what is the role of cardiologist in treating COVID-19 patients?
The COVID-19 is a virus which specifically affects the respiratory system. So it causes pneumonic change and pneumonia and respiratory distress. But a small proportion of these patients do develop something called a myocarditis, which is essentially an inflammation of the heart muscle. And that produces ECG changes and troponin elevation, mimicking a heart attack. So when patients do come in with respiratory symptoms, and if they have these ECG changes and elevated troponin, one of the questions we get asked is, do they need angiogram and to look for any heart disease and treating? My answer is simply no. I mean, we have to evaluate the patient. So we take a very good history. So if patients have a classic chest pain or some form of chest discomfort with ECG changes and troponin elevation, yes, they need an angiogram, irrespective of this COVID status. And we have offered them angiogram and treated. But again, it also depends on elderly patients. You could still manage them medically and avoid invasive procedure in them. But this is something a cardiologist should be aware that you do develop myocarditis, which gives a classic ECG changes and troponin elevation mimicking a heart attack. And the simple treatment for this is basically giving them beta blocker if they have valvular dysfunction, or even ACE inhibitor, although this is debatable. But if someone has got impaired LV, I personally would give them ACE inhibitor because it's an important drug. So essentially, it's a conservative management. So as a cardiologist, one should be aware that you can have myocarditis mimicking a heart attack, and you have to carefully evaluate this patient before offering them an invasive treatment. And the other aspects we get probably will be involved is that COVID-19 patients coming with a proper heart attack and whether to give them invasive treatment. My answer is if they need an angiogram, if they need stents, they should be offered. Although there are a subset of population like elderly patients, you could manage them medically.
Just to build on that, as you know, coronavirus case fatality rates for comorbid patients are materially higher than the average population. I read a study recently which suggested that for cancer patients it's 5.6%, for hypertension it is 6%, for chronic respiratory disease it's 6.3%, diabetes it's around 7.3%, but when it comes to cardiovascular disease it's 10.6%. Can you throw some light on why this is so? Is it due to pathophysiology of the virus, or do we know why patients with underlying cardiac disease are at a higher risk for novel coronavirus?
Look, from my limited experience I've seen so far, and obviously reading the literature, patients with established heart disease, especially if they have a left ventricular dysfunction, they do very badly once they get COVID-19. I think this is probably due to the fact that they are already compromised, and on top of it, they get an infection, which then puts their lung under pressure. And because heart and lungs are closely associated with each other, they do very badly. The other thing is, as I said, myocarditis earlier. So once they develop inflammation, there'll be a damage of heart muscle, there'll be a death of certain heart muscles. So essentially, if you already have, let's say, ejection fraction of 35%, and you develop COVID-related myocarditis and you drop your ejection fraction to 25%, then you do very badly because you've taken more hit on your heart muscle. So patients with heart disease, it's a combination of their poor cardiac reserve, further muscle damage from myocarditis, and the respiratory compromise, they do very badly. In fact, we have lost few patients in the last 2 to 3 weeks who had established heart failure. Moment they get COVID-19, respiratory distress, they have very high mortality.
Thank you. What kind of cardiac complications have you come across in COVID-19 patients? I've read some reports, I mean, obviously with limited data available, but some of the reports suggest that some patients, actual COVID-19 patients, actually recover from pulmonary infection, but end up having some severe cardiac complications later on, which is potentially responsible for fatalities. In terms of the discharge protocol, do you think there should be more wait and monitor approach? How do you see this?
Well, I think, look, as you know, COVID-19 can affect a large population, but not everyone gets ill to be admitted. And we also have to take into account the hospital reserve and capacity. So in our setup, if someone has got COVID-19 fever and myalgia and symptoms like that, if they've got no respiratory compromise, we in fact send them home. If they're hemodynamically stable, if they've got no breathlessness, we just send them home to say, look, stay at home, isolate yourself for a week or 2 weeks. If you develop any breathlessness or any other symptoms which is debilitating, then come back to the hospital. And the patients whom we admit are the one who have some form of a respiratory compromise, like breathlessness or pneumonic changes and things, or any heart problem, like if they develop myocarditis, LV dysfunction, hypertension, all these kind of issues. Once we are discharging patients with post-COVID, obviously we only discharge them once they are hemodynamically stable and they're doing well. So from the respiratory point of view, they do recover. Once they recover well. But if they have had an associated heart damage, and these patients have to be followed up, because once they have, let's say, left ventricular dysfunction, we follow them as we do with other heart failure patients. But the problem at the moment is we are not doing any clinics. All the activities, elective activities in the hospitals have been cancelled. So we are focusing mainly on COVID-19 and emergency care. So this probably is a slight concern, because when these patients go home, they don't know when are they going to come back to see us. It could be a few months before we reopen the service back to normal. Yes, you're right. So there are small risk of, a small group of patients who could go home who can probably will be vulnerable for fatalities, something which we have to work on.
Another most widely discussed and a hot topic in the medical fraternity at the moment is some concerns that certain classes of antihypertensives like ACE inhibitors or angiotensin receptor blockers could put patients taking them at a higher risk for COVID-19. There are some studies suggest this, and some studies suggest otherwise. However, the American Heart Association has advised people that elevated BP may rise the risk of complications if they are infected with COVID-19. And the American Heart Association has recommended patients to continue the use of ACE inhibitors or ARBs for hypertension and cardiovascular disease. What is your take on that?
Well, you're right. There are concerns about use of ACE inhibitor and angiotensin receptor blockade in patients, making them vulnerable for COVID-19 related complications. As you have said, that American Heart Association and also the European cardiology guidelines have given a statement, look, if patients are already on it, don't need to change it. Because some of them might be on for left ventricular dysfunction, heart failure, classic indication for ACE inhibitor. You stop ACE inhibitor, they will suffer from cardiac complications. So what my advice or my practice is, I'm not stopping anyone's ACE inhibitor. For example, if they have a LV dysfunction for myocarditis following a COVID-19, I give them ACE inhibitor. Or if they have a heart attack and if they have got COVID-19, or even if they don't have COVID-19, I give them ACE inhibitors. But if you're giving for blood pressure, you've got other drugs you can choose. So you can use calcium channel blockers, you can use diuretics, you can pick and choose the other drugs and avoid ACE inhibitor in those patients. But if they need an absolute indication for ACE inhibitors, you should give it.
You were saying that there is a limited OPDs that you are doing currently. In the current situation for patients, especially above 60, in a normal situation, they would have come to the hospital or clinic for their routine checkups. But that has changed now. What do you advise to patients, especially above 60? Do you suggest them to use telemedicine as much as possible? And what kind of complications, that, if they have, they should be coming to the hospital? And just to build on to the same question, obviously when you get a patient to the hospital now, we know that a lot of people with COVID-19 are asymptomatic. They don't know, we don't know. Do you send them for COVID-19 checks or to pathology lab, or you say you just attend to the complication without having to go through all that procedures? Could you elaborate a bit more on that?
Sure. So first of all, as you know, we have taken a big hit on our service from this COVID-19. So we have cancelled all the elective activities, or most elective activities in the hospital. So outpatient clinics have been cancelled. All the first couple of weeks, we did something called tele consultation, as you just said. But in the last 2.5, 3 weeks, we have completely stopped all the elective activities in our hospital, focusing mainly on COVID-19 and any emergency care they need. Now, no one knows what are the impact of this on patients who can potentially develop other problems from non-COVID related conditions like heart failure and things. We still don't know. We have to wait and see how this will pan out. I'm sure there'll be a lot of studies coming out in the future, the effect of COVID-19 on other non-COVID conditions. But what we are doing in our hospital is that we have sent out a letter to all patients, for example, waiting an angioplasty, saying, look, it's been cancelled because of this pandemic, but if you're getting a lot of symptoms, please keep in touch or contact us on this number. And those patients, we are bringing them, and we have a special unit called day case where it's completely isolated from the main ward, and we only house elective patients, and we offer them angioplasty as a day case. So they come in the morning and they go home in the afternoon. And obviously before that, we explain to the patient the risk of coming to the hospital and having the procedure done. But it's basically weighing the benefits and risks. So if someone has a lot of angina, in fact, last week I treated a patient with left main disease. He was having a lot of angina, and I could not have left him with that condition. So I explained to him, and he took a risk. He came, we did the procedure, he's gone home, and he's doing well. So there are patients, we are doing it. Although we don't know the long-term effect of this, change in the service. That's one of your answer. Now, COVID-19, as I said, not everyone needs admission. In fact, we strongly recommend patients, if they have fever or myalgia or any kind of cough and things, they don't need to be tested to know whether it's, and also testing is not always 100% sensitive. We have had cases where that 2 swabs negative and third comes back as positive. So I would suggest, if you got any of these symptoms, you just basically isolate yourself from everyone and stay at home. Only if you develop respiratory symptoms, or you start feeling, heart failure symptoms, like chest pain, those patients, they need to be evaluated, and we bring them in. We investigate them, and if you feel that they're safe to go home, we send them home. In fact, I've discharged a lot of patients in the last 2-3 weeks who shouldn't have been in the hospital because they're just worried. Of course, patients' anxiety plays a role, so you have to explain to them and send them home. But only patients who needs admission are respiratory, if they have respiratory distress. One other point you mentioned about is the swab testing or the testing for antigen and antibody. I think that is useful for patients or the healthcare professionals because if I do have some symptoms today, just fever, I can isolate myself for a week, which means my service to the hospital will be gone for a week. Whereas if they test me and if I'm come back as negative, then that gives me confidence to go back and work. And so the hospital will take me back for work. Whereas if they don't test me, then they lose my service for a week. And this could happen to a lot of healthcare professionals. So it's very important testing is done for the healthcare professionals, their first choice. And then if you go resources and service, then yes, do testing in the community like the way Americans are doing and Germans are doing.
Another most widely discussed topic across the world, both at a political level as well as at the medical fraternity, is the use of hydroxychloroquine and azithromycin combination, which could potentially cause some serious health risks. For the sake of this interview, we'll only stick to the medical side of the discussion. The reservation to use this combination, from what I understand, is mainly coming from cardiologists because cardiologists or the data that they have suggesting that it could lead to complications like severe electrical irregularities in the heart, such as arrhythmias, or polymorphic ventricular tachycardia, on long QT syndrome, or even increased risk of sudden death. Some countries are saying, look, we're not going to use it across the board, but we're going to select some cases, especially the severe ones, and we're going to use this combination. Some countries are saying, look, we don't have enough information. We have plenty of this medication, but at the moment, we're not going to use it because we don't have enough evidence that it would work. Where do you stand on this? Can you please clarify?
Yeah, look, I think these should all be evidence-based. I mean, the evidence is weak, so it's not proven it will work. And so there are three schools of thoughts. One, as you said, will say, look, we can't use this because we don't have any evidence. And that's what the approach UK has taken. I've spoken to our intensivist ICU consultants. They're saying they're not using it because there's no evidence to use it. And there are risks associated with hydroxychloroquine, as you just said. It can cause cardiac arrhythmias. And the second school of thought is, look, okay, we'll use only in patients who are severe, who got severe respiratory distress in the hospital setting where they're constantly monitored. Maybe you could consider, because you're monitoring arrhythmias, you can certainly stop it. So some countries are using in those patients. And third school of thought is, look, let's give it to everyone. Well, I think that's very dangerous because, in the UK, you can't just buy a drug. I can't just go to a pharmacy and just buy hydroxychloroquine because it has to be prescribed. So in UK, it's very, very nicely policed. You can't just buy it. I think, the evidence is weak. My feeling is that take an approach, don't use it because it's not proven yet until more studies comes out. Or you take an approach, okay, they should be used in monitored, severely ill patients, which is in a monitored setup, then yes, you can use it, but certainly not for general population, just going and taking some hydroxychloroquine if you've got some symptoms.
My next question is for your fellow cardiologist and also future to be cardiologist. I read a report, this is a survey done in the US, where they talked about burnout in cardiologists in the US, and the outcomes of the survey, it said 1 in 3 US cardiologists they have reported being burnt out. This is before COVID-19. And 58% of these cardiologists said they were planning to leave their current job, as per the survey. The number of cardiologists being burned out rise by 32% between 2015 to 2019. With COVID-19 in place, I mean, this is not going to go away in the next weeks, months. It might even stay for a year or so. How much workload is going to come your way as cardiologists, and what should cardiologists do to address this burnout in the next coming months or years?
Look, as a general rule, just leave the COVID-19 out. If you are a cardiologist or any healthcare professional, as a matter of fact, if you go to work in a busy job, yes, you can get burnt out. So it's very important that you balance your work and your personal family life to keep yourself, away from work for some time so that you don't get burnt out. It's very important. I think you have to strike a balance, and it's very easy to, especially when you're young and you have energy just to work, 12, 13, 14 hours a day and get burnt out over, because what we are is, we have to think this is like a marathon. Your cardiology career or any career, as a matter of fact, is a marathon, not a sprint. So it's very easy to sprint and then you realize that you can't complete your career or your rest of the career. I think it's very important. Now, COVID-19, of course, has added more or a different dimension to it. So, for example, as a cardiologist, we are now working in a shift system. So we are working 4 days in and 4 days off. And we work 12-hour shift in the 4 days, and then we get 4 days off. So where we try and relax and, mentally and physically, and then come back more fresh. I think that approach is probably an excellent way. But then over time, what will happen is there'll be less doctors on the ground, because they'll be pulled off. For example, we have something called Nightingale Hospital, which is being used in NEC in Birmingham, where some of our doctors will be taken, so which means we'll feel the pressure on the ground in the hospital setting. Yes, it can happen, but the best way to balance is you have to support your colleagues, you have to work in a team, and maybe in a shift system, and cutting down all the elective activities, because that's why we're done. We cut down the elective activities so that we are not busy from that front, so that we can focus on COVID-19 situation. No one knows how long this is going to last for, but my advice for cardiologists is to strike a balance. And I'm not speaking just for cardiologists, for everyone. In fact, I've got more worries for the nurses and the frontline physician who deal with these patients, day in, day out. They're more vulnerable than us, and I've got more respect for them. So they have to probably, take turns, work in a shift system, have enough time for relaxation. It's very important.
Artificial intelligence use in medicine is one of the hot topics recently, especially for intervention cardiology. What is your take on use of artificial intelligence in the diagnosis or even treatment procedures? And are you using any specific tools in intervention cardiology which are AI or artificial intelligence based?
So artificial intelligence for cardiology, we have something called robotic PCI. Essentially, you are standing away from the radiation, sitting behind the screen, and you can still operate on patients. We have just started getting in the UK. We don't have it in our center, and there are certain centers in the UK they have started using it. And of course, in America, it's a big thing. I've seen in some live cases they're using it. I think that is something in the future will happen. So you can probably, even they're saying you can remotely use it from your home or from your office. You don't have to even go into the cath lab. I don't know when that will happen, but I think that is the way forward. Remember, you mentioned about what are the advances in cardiology. I think this is one of them, which will probably take on more and more. In regards to COVID-19, I don't know the use of artificial intelligence. My knowledge is very limited on this. But all I can say is that I think we should work towards more of antibody testing.
I have one more question, which I was meant to ask at the start. This is related to statin therapy. Is there a role for statin therapy in acute viral infections? Is it conceivable that the patients admitted with viral respiratory illnesses, including COVID-19, could derive a beneficial effect from continuation of their statin therapy?
Look, there are some reports in the literature where, when you have a high sensitive CRP and patients with heart disease, they do well with statins. But whether you can use it for COVID-19 or any flu-like illness, I don't think so. There's no evidence to suggest that you just have to prescribe someone a statin because they are vulnerable for COVID-19 or they have COVID-19. It's like chloroquine, hydroxychloroquine, no data. So I don't think so. We should just use statin. If someone's already on statin, if that's protecting them, great. But I wouldn't prescribe statin purely for this flu or COVID-19 situation.
I get a chance to speak to people from different walks of life. That includes policymakers, businessmen, common people, doctors, technical people, all kind of people. But there is one thing which is repeatedly being said across many countries that I have interacted, is that COVID-19 situation has really exposed the loopholes in our healthcare systems. Which probably wouldn't have looked at if this had not happened. Again, every country will be looking at whether we are putting the money in a place where it really matters or not. Hopefully, some of those loopholes will be addressed in the coming years or months. There is also a lot of discussion about shortage of doctors, specialists like you. How much of shortage is there for cardiologists in the UK? And do you think we need more doctors in the world?
I think that certainly we need more doctors in the world. There's no doubt about it. Whether irrespective of this COVID-19, of course, that puts we are under huge pressure. People going off sick, and so we need more doctors certainly. As a whole, there's a lot of inequalities between the number of population and the doctors serving them. No doubt about it. But to answer your question about what's the future role as a policy making, and I think no one was prepared for this. I mean, I don't think so anyone anticipated that this is going to be a pandemic affecting globally in such a enormous scale. So I was watching the video by Bill Gates in 2015 or 16. I think he gave a TED talk, and he kind of said we are not prepared for this kind of pandemic if it happens, and no one kind of took it seriously at this time. I mean, it's not that they should have, but anyway. But what I'm trying to say is that for the future, now it's like a warning bell. We have had this warning bell of this COVID-19. Who knows, with the next future strain of another wild virus might be even more aggressive. It may affect children. So luckily, touch wood, so far the children are least affected, and who knows, the next virus may be affecting them. So I think we should probably be prepared for these kind of pandemics, especially because the traveling is so easy these days. We all travel globally, and that's how this infection has spread so quickly and across the world. I think for the future we have to probably take a lot of precautions. In cardiology, as you said, we are probably are least, or I wouldn't say least, probably less affected in comparison to frontline physicians, nursing staff, intensivists. I think there where you need more workforce. So we're supporting the frontline staff. You need more doctors in that field. So definitely more doctors are needed. Well, the other thing I would say is that there's so much emphasis on the healthcare workers now. I mean, I'm sure globally and in the UK, we do get this clapping every week at 8 o'clock. People clap. That inspires us to continue doing this good work. And more importantly, it should also, and I'm sure it will, influence or give stimulus for a younger population or younger generation to become doctors. I think it's a great profession, and this situation we're dealing with will probably inspire a lot of young minds to become a doctors. So yes, of course, we are in a situation where we could see positive from it, that we'll probably get more doctors in the future.
Dr. Sandeep, thank you very much for such an insightful and interesting conversation. I'm sure a lot of audience will enjoy it. I'm sure we get a chance to speak to you again on some of the topics. We only just touched base today, and thank you once again for giving us the time.
Thank you for the opportunity. And I'm very happy that I'm able to provide my input on this. And I'm sure we will speak again, and very happy to help out. Thank you.